Hey everyone, thanks for dropping in. We wanted to do a special episode for International Women's Day, and we got access to, luckily, Dr. Ariel Dalfen, who's an expert in women's mental health. This podcast was illuminating because there's a lot of stigma, especially around, I think, perimenopausal mental health. There's stigma around perinatal mental health when you're having a baby, and all kinds of things can create anxiety, depression, all kinds of mental health stuff can happen in that time of life for a woman who's pregnant, and then also for a woman who's going through menopause. And those are two big areas of study and intervention that Dr. Dalfen works with thousands of patients on this in her clinic and with her application, where she works in a telemedicine type of way to make sure that everyone who's going through this can get access to physicians and train other healthcare practitioners. Super interesting. I learned a ton. Dr. Dalfen has a really nice way to put things into simple buckets: bio, psychosocial, what we see, how we treat it. So I always appreciate when high-level thinkers can make things more simple for me to digest and understand. And I think that's what you'll experience today with this podcast. So thanks for joining and welcome to the show. I'm Dr. Ryan Todd, a psychiatrist with over a decade of experience. And in this series with leading experts, we will explore the complexities of mental health, breakthrough therapies, and today's hottest topics. This is Beyond the Checkbox, Mind Masters. You saw early in your practice that there was gaps in women's mental health. And I guess the first question I was thinking about was, what made you interested in women's mental health specifically? Because our training is so general. Like, we get exposed to like everything, and everything falls in this big bucket of stuff. And what was it about women's mental health that kind of drew you to that? And what were the needs that you saw initially?
Well, thanks for asking. Good question. I mean, I think first of all, being female myself and having a very little bit of exposure and a little bit of training, especially towards the end of my residency when I was looking for another opportunity. And I was exposed to who's my now business partner, Bev Young, and she had some expertise in that area. And I approached her to basically say, can I do an elective with you? And I'd always been interested in women's health, women's issues. That was one of my main motivating factors to actually go into medicine at the start. And I was first interested in obstetrics and gynecology, but quickly realized that I was much more interested in psychiatry and understanding how the brain works and behavioral health issues and emotional symptoms, plus the interest in women's health. So I came into medical school and medicine and residency with that as a background interest. And then when I actually did a little bit of training in it, I found sort of the one person that at that time, this was over 25 years ago, who could do that. I found it fascinating looking at the nexus of a woman's biology, physical changes, hormonal changes, how that could impact someone so dramatically at very vulnerable stages of life. And it was also encouraging to me how much we could intervene at that point and really make a difference. And then people got better. A lot of the people that we were seeing would be quite ill at this stage of life, maybe have a background with mental health problems or not, but people really did so well. And I found that very satisfying to be able to intervene, see improvement in people, and make a big difference to not only them, but to their relationship, to their family, to the future. So that became very satisfying, and that became something that I really devoted my career to from there on out. And I worked in women's mental health and perinatal mental health specifically for many, many years.
And what you see you see dramatic improvements, especially with, in my little experience with like postpartum depression, postpartum psychosis, mania.
Absolutely.
Like you can treat it, and something that I don't think anyone would have insight into until you practice medicine is there's a lot of stuff you can't treat, and that's demoralizing for a physician. Like, I could never do neurology. Like the neurologists I
Right.
know are saints. They just care for people who are in such, their brains are just in disrepair, and there's not always treatments, and they have to just
Right.
stand and be with that person. And there's an
Yeah.
element in that in psychiatry, and it sounds like you
Right.
found perinatal mental health to be really
Hmm.
rewarding.
Yeah, and that's the same with the mental health we do across the different life stages where there's hormonal changes, psychological changes, role transitions. Mix all of that together and there's so much going on at these distinct stages and then people can work that through and really go on to feel well. So unlike neurologists who are like, let's find the lesion and watch it, I feel like there's really a very much role for people being actively engaged in care, actively guiding their care, using an array of different services, and then coming out really healthy on the other end.
Like, women's mental health wasn't always a thing. Like when did it start to emerge, and like what were some of the initial, like, hey, actually I think women's mental health is different than men's mental health, because it wasn't always like that, and the field isn't that old really.
No, not at all. Well, when I started, it's interesting. I like to think I'm a bit of a pioneer in the postpartum movement because when I started, it was just the early days of starting to talk about postpartum depression, which then everybody started to talk about as postpartum. I have postpartum, or I want to prevent postpartum, and then that became something that we talked about and that we tried to modify or limit risk or actually treat and get information out there that there are medications that are compatible to take during pregnancy or while nursing and certain types of therapy that can really help people and that we can destigmatize it for women who are super ashamed to come forward with it. In fact, I even wrote a book for the lay public about postpartum depression. It's called When Baby Brings the Blues. It's still available. And so I feel like I was part of that movement to really destigmatize and inform people and the public and other healthcare providers about postpartum depression and then depression and mental health issues during pregnancy. And I think as my cohort of psychiatrists and mental health care providers has aged into perimenopause and menopause, we've kind of brought that fighting spirit with us. And now we're talking so much about perimenopause and menopause. I don't know if it's true for you, but I know amongst me and all my friends and female colleagues of my age, like our feeds and so much information and listservs are all about perimenopause and menopause and destigmatizing mental health problems at this stage and informing people about the evidence for using menopause hormone therapy effectively and carefully and using the evidence that we have to destigmatize what really became a taboo subject of menopause hormone therapy and talking about women and aging and mental health issues. So I can't really pinpoint a date to your initial question, but I feel like it slowly happened maybe 20 years ago around the postpartum years and has aged up with us now to be around the menopause and perimenopause years.
The stigma around mental health and pregnancy is really interesting because it's supposed to be the perfect time. Like
Mm,
everything is great and you're glowing and like a celebration, and of course I didn't have a baby, my wife did, and I found like the first year to 2 years of having a kid to be one of the most difficult times of my life. Like you go
hmm.
through like, oh, it's a new kind of life. It's way different.
Totally.
And in medical training, in a weird way, it's all about you. What's your learning and what are your
Right.
experiences and like how do you improve?
Right.
And it's a very self-indulgent field in a way
Yeah.
because it has to be like you have to figure out all the knowledge to like help people.
Yeah.
And then that switches like instantly when you have a baby, and then like you 10x all those emotions when you actually
Exactly.
have a baby and you're not just like a
Yeah.
useless father like me. Um, so can you walk me through the biopsychosocial of all that? Because there's like a massive hormonal change that I don't think people understand well. There's
Yeah.
psychological changes in stigma, and there's also this like social element of depression in pregnancy and after
Mhm.
pregnancy that I think is so interesting.
Yeah. So it sounds like you've explained it really well. I'll add a little bit of detail on top of your explanation. So as you know, we as psychiatrists look to and use the biopsychosocial model to understand a couple main things. One is who is at risk, and then to map treatments on that to limit risk and to put into place good treatments to actually help people feel better. So, if we're looking during pregnancy and the postpartum period, some of the major biological factors that put people at risk are one, having a psychiatric history prior to pregnancy. So, people who've had depression, anxiety, even bipolar disorder, other maybe schizophrenia, other psychotic issues, they, because of the interactions on their brain of the pregnancy hormonal changes, um, and postpartum are at higher risk of developing problems at that stage of life. So there's that background, and that's not something modifiable that people can actually change, but it's something that we help to educate all our patients about how to minimize risk and to be aware of. So there's that one, number one biological factor. Then having a strong family history of mental health problems, or particularly mental health problems during pregnancy and postpartum. As people are getting older, people are starting to know more about their mother's issues during pregnancy and postpartum. So that's very valuable information as well. And then we have things like other medical concerns that maybe happen to people during pregnancy. Examples are thyroid issues, low blood iron levels, anemia. Some of these can mimic symptoms of depression or anxiety, and they're very common for people to struggle with during pregnancy. Then, if we look at sleep issues, because pregnancy disrupts our sleep mechanisms, that's another major biological factor for people who are at risk. If they have really poor sleep in pregnancy, really poor sleep postpartum, that's going to put them in a higher risk issue. So those are what I would say some of the major biological factors in the perinatal period, which means both during pregnancy and postpartum. And then we get to some of the psychological issues, and we think about that in terms of what's a person's psyche, what's their mindset, how do they approach the world. So a good example is of someone who are at risk, or what we call neurotic or type A personalities, have a known higher, and perfectionistic people have a known higher risk of especially postpartum mental health issues. And that's probably classically your professionals like us, like your type A doctor, lawyer, teacher, nurse. Those are probably the people who we see the most. And what I spend a lot of time talking to people about is these people with these types of personality structures, and of course, there are many others who may have that, regardless of their profession, are people who are used to being in control, having an orderly life, working on a schedule, and having those things in place and like working through A to B to C. That gives me my sense of mastery. Then I feel good. Then I feel calm. I know what my days are going to look like. I know what I need to have in place in my schedule to feel good. When you bring a baby home, of course, that's the perfect storm. You don't have any schedule. You can't work out. You can't, get all your marking done at a certain time. You can't get all your charts done at a certain time. Your days feel like nights. Your night feels like days. Like you can't put those things into place. There's no order. It's actually mostly chaos in the first few months of bringing a newborn home. That is so destabilizing for many people who have that type of personality structure. So that leads to a lot of anxiety, often a lot of depression. People are like, I'm not doing anything right. I can't keep my house clean. I can't do all these chores. I don't feel on top of anything. And it's extremely unsettling for people. So we help them unpack that and look at that. And then we look at, and there are some other psychological factors as well. And, people who've had a history of having abuse or neglect or violent upbringings and situations. And that's created certain stressors, certain psychological developmental issues that also puts people at a higher risk. And then we look at some of the social factors, starting within the home. Is a person on their own? Do they have a supportive partner or not? Are they in a safe home? Are they a victim of domestic violence? Then looking at other social structures. So, for example, during COVID, when people had no access to support groups or physicians, or even at points during COVID to their larger family structures or friend structures that are so important for mitigating the risk of mental health issues, people didn't have those. And still, many people don't have those for a set of other reasons. And we look at other social factors that are going on in people's lives, in their world, in our larger culture, living through very stressful times, living in poverty, living with, lack of access to good health care. There are a lot of different factors. And then you throw everything that I've just mentioned into the mix, and someone is trying to learn how to be a parent for the first time or for the second, third, fourth time, and adding stressors in. And you can see how someone would be at high risk and develop these mental health problems. So that's the model we use to understand risk and look at different risk factors. And then we layer treatments onto that. So if someone themselves has had a mental health problem prior to pregnancy or prior to baby, we want to make sure, first of all, are they medically healthy? Have we looked at their thyroid? Have we looked at their iron levels? Have we made sure to rule out other sleep disorders? Have we made sure to rule out other medical issues that are contributing? Are they on medication to support if they've been on medication before and have had relapses if they've come off medications? Do they need to be on medications again? Do they have do they have access to good therapy? Because both therapy and medication is really the gold standard for people, especially with more moderate or moderate to severe types of perinatal mental health issues. And then we try and support with as many social supports that are available, starting with, do they need couples therapy? Do they need family therapy? Are there local community supports available, support groups available? So that's a really long-winded answer to your question, but hopefully shed some insight onto how we think about it and what we do.
Yeah, and it's so interesting how, like, it kind of makes you wonder why anyone would want to get pregnant. There's so much that could go wrong. Do the same principles apply to perimenopausal mental health, if I'm saying that right?
Yeah.
You can, for women's mental health, you sort of see these two anchors, like these two massive life transitions. And the third thing I want to ask is, like, what about the stuff in between? But do you apply as a practitioner similar principles to perimenopausal mental health?
Absolutely. Absolutely. So again, the biopsychosocial model is very helpful to help us understand what's causing what. So during perimenopause, the major biological factors that everybody who goes through perimenopause goes through are vastly fluctuating hormone levels. And so we want to know, what is the impact of the vast fluctuation? Well, it could be people having hot flashes, night sweats, joint pain, brain fog, could be mental health concerns. So we want to look at, is there a way for us to intervene biologically to treat hot flashes and night sweats, which the consequences of those are, if you're having night sweats through the night, then you're not sleeping.
Yeah.
That's going to put you in a really bad state during the day, make you more susceptible to depression, to anxiety, etc. So helping people understand, are they good candidates for menopause hormone therapy, which many people are. Then we want to look at, so are there biological treatments or biological interventions for some of the perimenopause symptoms that they're having? And then we also look at the life stage changes, role transitions at work. Being an aging woman in our society isn't always easy. Our body's changing, our physical looks changing, dealing with pain, dealing with increased rate of medical issues, and then dealing with relationship transitions at the other end. Kids leaving home, or maybe kids not leaving and you really wish they would leave, or them coming back again. And relationship issues, if people are left with their own partner after kids have left, thinking like, okay, do I still like this person? Do I still love this person? What does my relationship mean at this time of life? And having to navigate all those transitions at home, in the workplace, and doing that all the while managing for many people, pesky symptoms of perimenopause can be really challenging. Plus, it's important for people to note that people who've had perinatal mental health issues often are the same people who are at risk of perimenopause mental health issues. So those people who are susceptible to hormonal changes during pregnancy and the postpartum period, during pregnancy and the postpartum phases, are the same people who are going to have struggles later on in life, a lot of the time. Not all the time, but that's definitely one risk factor. And then you asked about the whole time in between. We often always want to ask about what we call premenstrual dysphoric disorder. So that means very severe PMS, premenstrual syndrome. And so again, that is people who, let's say they have an average 4-week menstrual cycle with ovulation that occurs in the middle of that 4 weeks. That's sort of the typical cycle for most people. In the last 2 weeks between ovulation and between them getting their period, people who have severe PMS will describe suffering with very significant depression or anxiety. They feel like that point in the middle of their cycle, a switch has been flipped and they're a totally different person. They're angry, they're sad, they're crying, they're super sensitive. And that is people who have that type of constellation of symptoms are often people who've had severe postpartum depression and maybe at risk again during perimenopause. So you see the theme of, with a subset of people, many people have a vulnerability to this hormonal fluctuation that women experience across the lifespan. So we want to be able to identify that. We want to be able to help people track that. And we want to subsequently really treat that.
How do you prepare people for, like let's say somebody sees you and they have a previous history of a mental health issue, and you're preparing them for pregnancy or preparing them for menopause, because there's a lot going on and a lot of risks there. How do you tell people what they're getting into, or how do you help set them up for success? Because so much could go wrong.
Well, we walk them through it we try to break down all the different factors when we're seeing someone. So, it sounds like a lot and it sounds super overwhelming. So I walk through what someone's risks may be. And sometimes that's actually very helpful for them to know, okay, I'm not going crazy. You understand what's happening to me. This is normal. This is relatively common. And the good news, Ryan, that I really want to impart to you, I know it's a lot of information I'm throwing at you, and there's a lot of places where things can go wrong, but there's also a lot of great treatments. There's a lot of ways that we can intervene and really help people feel better by breaking down all the different symptoms, breaking down the biological, the psychological, the social factors, and plugging in those, risk factor areas with good treatments and education and awareness. And so that goes a really long way towards helping people feel like they can break down their symptoms, they can understand them, they can put in place different treatments that are going to help with each one of these areas and actually get to a better place. Like, as I started off by saying, what I love about women's mental health concerns is that people also do get better, and people can get better. But it's a question of finding the right healthcare providers, the right healthcare team, really often, to get you through these different stages.
Is there still stigma around this? Like, my intuition is saying that there's more stigma for some reason around perimenopausal mental health stuff. My intuition is always also that like the postpartum depression, I have postpartum thing, sort of destigmatized it around perinatal mental health. That said, I've known a lot of people who are really close to me whose partners have had kids and they've really struggled for like 6 months or a year, and you find out after the year they're like, they had like severe anxiety after having a baby. So I don't know, where's the stigma? Like, we've seen stigma in the workplace dramatically. Like, when I started training, we didn't talk about mental health in the workplace. And now stigma has been reduced significantly. More people are feeling comfortable accessing. The stigma might be still there or not. Like, what's your take on, if there is stigma, where is the hottest stigma right now?
I mean, I think there is, to your point, there still is stigma around postpartum mental health issues because, as you said, it's the time when you're supposed to have wanted this all your life. You're supposed to be glowing. It's supposed to become natural. So a lot of people still really internalize shame, which is unfortunate. I think many fewer than did when we first started, and people are aware of it, but it still exists. And it exists also, I would say, unevenly across different, maybe cultural groups, different ethnic groups, different religious groups. There are still pockets where it's still very shameful. And there are other pockets that have come a long way. I still think we have a lot of work to do. And I still think we have a lot of training to do for healthcare providers in that area, because so often we hear people will say, oh, I went to my primary care provider, and this is no shame on them. They just haven't been educated. And they'll say, oh, don't bother coming to me. This is normal. It's a hard time of life. No medications are safe anyway because you're pregnant or you're nursing. None of that is true. But people hear that and then they're like, oh God, it must be me. I must be, this must be really problematic. So there's a lot of educating we still have to do because that's another barrier that people face.
Yeah.
And then as we get to perimenopause, I think you're right. It's sort of becoming less. Conversations are starting. But I think that's also compounded by ideas in our society about what an aging, about, stigma against women aging, what they would look like, women being crazy as they get older, and there's stigma around that, and people internalize that and think, oh, I'm just getting older, I must be hysterical, and I must be just must be me not being able to cope well at this point of life, and I'm getting older anyway, so going out to pasture. And so there's a lot of stigma around mental health issues to begin with, around brain health, and around aging. And so a plot put all of that together, and it keeps people really silenced.
Yeah, it's there's a lot to dig into there, because there's when you go to the bottom of your news feed, there's always like the good-looking people part of the reel, and it's all
Yeah.
about like how men are aging gracefully and like how
Right.
good George Clooney looks with like the salt and pepper, and it's all about how like Demi Moore still looks like she's 20. Like it actually works in the opposite. Like guys,
Totally.
somehow men have been labeled as like aging gracefully, and somehow
Oh,
women
yeah.
are just meant to like fight aging, and like it's a bad
Yeah.
thing, like it's a demon that is coming to get you, and you have
Right.
to do all these things to fight it. And so what I hear you saying is that applies to mental health too. Like you
Hmm.
get like more crazy in your old age, or more like isolated, and like that's a I haven't really thought of it like that. Like we have all these
Hmm.
internal biases about how
Hmm.
the female brain ages as well. We have stigma around
Hmm.
that.
Hmm.
And I
Yeah, we
imagine
have our
that,
work cut out for us.
yeah. And I wonder how that applies to the workplace too, because I think yeah, I saw a lot of posts around International Women's Day, and like some of the barriers that especially senior female leaders have compared to male leaders. Like there's an assumption almost, if it's like a tall, Caucasian senior male, they like know what the hell's going on. But I don't think those rules apply to females. And I wonder if those unwritten rules, I should say. I wonder if you see that in your practice, where women who are perimenopausal are also struggling with their roles at work and how they're viewed at work.
Absolutely. Absolutely. Menopause in the workplace is a burgeoning area. It's a very hot area that people are starting to talk about and offer education and training in workplaces around how workplaces can become more menopause friendly, what people need to do to speak up to make their role more comfortable. Because there are a lot of statistics that show that women at the primes of their life, when they're entering perimenopause and menopause, are leaving the workforce in very high numbers because they're struggling. Maybe they're struggling with brain fog, or they're struggling with not being able to feel like they're being listened to, or feeling shame that they're having hot flashes in a meeting, or feeling like they're crazy, or they're just overlooked for things. So that's a real thing. And there's a lot of talk about how to counteract that and how to support women, be able to speak up and talk about what they're going through, and for workplaces to become more friendly by, even having cooler temperatures or offering people fans, or because people have such bad sleep often in perimenopause, maybe adjusted hours for people, or like a cooling off room, or, I've seen all kinds of those recommendations for corporations or workplaces to start to implement these and to really pay attention to women, because women at this stage also offer so much. They have a lot of experience, they have a lot of knowledge, they have a lot of ability to really contribute a lot to organizations. But when they're stymied by symptoms, or they're stymied by a workplace that feels unfriendly, they're leaving. And that's a disadvantage to both them personally, individually, career wise, as well as to many workplaces. So there's big conversation around this now.
Yeah, and I'm wondering like what it would take to make the workplaces more friendly. Like there's some physical environment adaptations, there's some education that needs to be done, but there's like also like a stigma or a mindset that is
Hmm.
sort of unspoken. Like in having this conversation, I'm interested to think about like even you don't really hear, and I think this is a marker of stigma. You don't really hear senior executive females saying, "I'm going through menopause." Like it's sort
Until
of
you
like,
start the conversation.
yeah,
You may not hear it, but I hear it because I have
yeah,
these
yeah, yeah.
conversations with people all the time. But you won't hear them talk about it publicly until there's like a big campaign or a big push, and then they're like, "You're suffering with that? You're suffering with that? Me too." Like then you open up Pandora's box. Like it is there just beneath the surface, and it's starting to come more.
And the thing I'm trying to like figure out is why there might be more stigma in that than like perinatal mental health. But like I think there's almost now people have a like, oh, you had a baby, there's a reason why you could be depressed. Like people want to attach a thing or a reason to why that thing might be experienced. And it seems like there's like, well, everyone goes through menopause if you're a female, so there's no reason for you to be depressed. So I think that layers onto the stigma of it all.
Yeah, absolutely. And the lack of knowledge about what the actual impacts are of the symptoms. Like there can be, not everybody, but there can be very significant symptoms that people have. And either they minimize it themselves or people just don't know about it. And again, it's a bit of a circular situation because many women who struggle a lot will go to their care providers, their primary care providers, and the doctor will say, suck it up. Like, everybody goes through this, don't worry about it. So then people think, well, I must be crazy, why is this so hard for me? So then they think, okay, I'm just going to go on the down low with this, and because it's so unpleasant, I'm just going to quit my job and try and manage this, and like try and chase down some other diagnoses, and they spin their wheels, and then people just self-silence because they're told by someone they theoretically respect, i.e. their healthcare providers, that it's like, we can't do anything for you anyway. There's no treatments that are safe. Like, menopause hormone therapy is not safe. It's not effective, blah, blah, blah. So it really takes people out of the mix and out of the running of in their career or at work, and they self-silence. So I think it's a bit of a thing that people just end up suffering with on their own because they've been gaslit a lot. I know that term is overused, but it is so applicable. It is so applicable. Like, I can't tell you how many women a week come to us at Bria, at my clinic, and say, I've gone to my doctor 3 times and I keep asking for this. And I even and they keep saying, no, like, forget it. I'm not giving this to you. It's not safe. Or they get all kinds of really strange combinations and permutations of non-evidence based treatments as workarounds that are ridiculous and potentially unsafe. So people just, turn the other way and don't talk about it.
And suffer. Yeah.
Yeah.
What I want to talk a little bit about the organization that you started and the technology part of it. What are you most excited about where the field is going? What do you think is interesting? What do you think have been some of the best advancements in the field? And yeah, what are you looking forward to in this area of work?
Well, I think what I'm really excited about is continuing to speak very loudly about perimenopause, menopause, and mental health issues, and aging, and destigmatizing mental health in older women as we age. And I feel like we're on the, we're talking about this, we're starting to talk about it more and more and more. So I'm really excited about that because I think there's a lot of opportunity to actually help people. As I mentioned to you before, we're doing a lot of training of healthcare providers so that women have another place to go and they're not going to be gaslit. They're going to face informed healthcare providers who can actually help them, who can advise them, who can guide them well. So I'm really excited about that. I'm excited about the interest we're getting from healthcare providers to want to learn more, not only about the physical aspects of perimenopause and menopause, but the mental health aspects. As a psychiatrist, that is very exciting to me. I think more and more people accept virtual care. I think more and more people are willing to seek therapy now. I think I'm excited that more and more benefits cover it. More and more workplaces encourage people getting mental health care and cover it. People have better coverage through the years. That's increased a lot, which makes therapy more accessible to more people. I know we have a universal healthcare system in Canada, but as you and I both know, it's actually not universal when it comes to mental health cares, therapies, sleep support, nutrition support that we offer, but are not covered, but are essential pieces for people recovering from mental health issues. So that's exciting that there's sort of a general social trend towards more coverage, more value placed on it.
Yeah.
And for that to continue.
Yeah, I love that. And I think the workplace it's an interesting lens for all this because,
Mm-hmm.
stigma starts to be, I feel like stigma starts to be reduced in sport and art. And like those are the first individuals to kind of bring it up, like an athlete or a musician. And then it gets implemented in the workplace. I always
Right.
had that intuition. And I think that this is one of those examples, especially around perimenopausal mental health.
Certainly
So
celebrities,
yeah,
actors,
yeah,
actresses coming
absolutely.
forward is helps the cause. It helps and it doesn't help. I will say, like, I would argue with you a little bit because there's a lot of shilling of crappy products that are getting people to part with their money and stuff that are actually not great evidence-based treatments that people are so desperate that that they'll buy. So I agree with you that it helps with the conversations, but sometimes women in particular get led astray by endorsements and people trying to make a buck on off their suffering.
I could absolutely see that. So, yeah, I mean, thanks for coming on to talk about this because it illuminated a lot around, even with all the training that I get, we don't get a lot of training in this, hey? In like women's
No.
specific mental health. Like I remember a couple of like training stations on it, a couple of like cases that you'd see, but it does still seem like a bit of a black box, which tells me that even psychiatrists or specialists don't get enough training in this area.
Yeah.
So yeah, I'm really grateful for the work you do and for coming on the show to talk about this and the advocacy. So we'll continue to
Thank you.
watch how you're being loud about this because
Thank you.
it's pretty cool to
Thank
see, and
you.
our listeners really appreciate it. So thanks for coming on the
Thanks for
show
having
and
me.
spending a little time with us today.
Great to be here. Thanks, Ryan.